Madeline, putting up the slides again, and this time on to how ARC South London works, just for those of you that are not familiar. So we have research themes at ARC South London, and these are based on, you can see them in the green boxes there. These are based on the needs of South London, as were described when the ARC came into being 3 years ago. And previous to that, there was the Clark, which preceded the applied research collaboration. And as well as the themes, which are kind of obvious to people around alcohol, children and young people, maternity and perinatal mental health, palliative and end of care, public and patient involvement research, public health and comorbidity, and social care. We've also got cross-cutting themes which help us to do the work in applied informatics, capacity building, which is building the skills and capabilities of our people, economics and biostatistics, implementation research, so how we actually get things into practice. And actually we're around the outside of things. So we've changed our name from implementation engagement in the blue around the big circle around it to implementation and involvement. And involvement means, in its broader settings, is about how we involve people and communities in the research and the research needs and the implementation of research, everything that we do. So thank you, Madeline. Can you move the slide on, please? This is my last slide, just to introduce things. This looks a bit complicated, but I just wanted to highlight some of the work we've done in the involvement team about really trying to bring a kind of equitable and diverse input into our ARC. And some of the things that we engaged the public in informed us that we needed to have public members on our board and executive. And so you can see that in the top two boxes. So those were structures which already existed, and that there should be links by these people also attending the public research panel, which is new, the involvement advisory group, which is a core group which advises both the executive, the board, and us as an involvement team about what we need to do. And then the most important people really are in the middle here, all of the research themes in the blue boxes. Each of these has an involvement champion, and the work of involvement is essential to all of the themes. And everyone here is part of a learning network, the involvement learning network. And we have, educational or kind of network events. This is considered to be a kind of network event, but it's open to a wider audience. So that's all I really wanted to say, just to sort of situate you into this active involvement and research evening. This is part of the involvement team and the structures of ARC South London. And it's my great pleasure really to hand over to the chair of the involvement advisory group, Rashmi Kumar, who's going to welcome us to this specific event and take you through the next steps. Thank you so much, Rashmi.
Thank you, Natasha, and welcome to all of you. It's so lovely to see so many faces, and it's nice. And
I sort out my screen.
Yep. So hello, and thanks for having us. It's great to be able to talk here. And again, I recognise quite a few faces, so it's nice to see you, and at least one member of our PPI team.
Okay, brilliant. So I'm going to start then. So Jane and I are going to do a double act for 10 minutes. We're going to present about our patient and public involvement on a research programme called Empowering Better End of Life Dementia Care, EMBED-Care for short. This is part of the theme on palliative and end of life care. So the slide that we just saw around the different themes within the ARC for South London, this is one of the adopted projects within the theme on palliative and end of life care. So this is a joint study between us at King's College London and colleagues at UCL. I co-lead the programme with Liz Sampson at UCL. So I'm very pleased that you asked us to talk to you about the research and specifically about how we have changed our public involvement during the pandemic and the benefits that this has brought to our public contributors and to the impact of the research. So first of all, just very briefly, what exactly is EMBED-Care? So as I said, it's a 5-year programme, and this rather busy slide just details the different work streams in the programme. And you can see that there are 6 work streams. We're about halfway through the programme currently. And what we're trying to do is to empower people with dementia of all ages to be able to better manage the many distressing symptoms and concerns that people experience, to enable individuals with dementia to live life as well as possible and their families. And over here on the left-hand side of the slide is a key pillar of the programme, which is our patient and public involvement. So this runs throughout the whole programme. We've worked very hard with Jane as our chair of our patient and public involvement study reference panel, and with the members of that panel to enable their involvement within our research and to maximise the impact of their involvement. So our involvement with our public contributors, and those public contributors are individuals who are affected by dementia. So they are current carer, previous carer, and also individuals living with dementia. So it's quite a wide range. So before the pandemic, we had quite a traditional approach to public involvement within our research. So we convened a reference panel for the programme. We met with that panel about every 3 times a year. We worked with Jane, who was the co-chair of that panel, in devising the agenda, in running the meetings, and we held those meetings at points that were probably most useful for the research. And those were in person. So colleagues were travelling quite a long distance to be able to attend those meetings. We provided lunch so that it was a nice experience, but it was quite demanding on people. Then what happened during the pandemic was, like for everything, was that we could no longer meet in person. So we then switched to virtual meetings. And what that enabled us to do was to rethink how we were working with our public contributors. So one of the first things that we did was obviously to reduce the length of the meetings. So they were cut down to a maximum of 1 hour, with the view that that was more than long enough. That was any longer than that was really quite uncomfortable for people to be sitting in front of a screen. So by reducing them down to 1 hour meant that we could hold our meetings more frequently. So we moved to holding meetings roughly about every 2 months. We were obviously reimbursing costs for people's time, for carer costs when that was needed, and also some infrastructure costs, obviously in the recognition of people's own electricity and Wi-Fi. And this enabled us to achieve 2 important things really for the programme. The first thing was that our public members were able to support our PhD, our fellows. So these are individuals studying for a doctoral degree. And that was really important because capacity building of researchers in research on dementia care is a key component of the programme. So being able to better train those researchers in public involvement across the 4 years of their doctoral study was something that we were really excited to be able to do and to be able to offer that to them. And the second component was that it enabled us to have a wider reach to people affected by dementia. So being able to connect with people virtually meant that we were then able to connect with people nationally rather than expecting individuals to come to us in London. So I'm now going to hand over to Jane, who's just going to talk about the first element, which was around supporting our doctoral students.
Yeah, and as Catherine said, we've got a great group. So within the patient group, we've got ex-carers, we've got people with dementia, we've got people who are very experienced, we've got people who are new to this kind of work. We've also really been lucky in that we've got people who have wide experience of dementia. So we've got people who, the usual forms we'd expect, Alzheimer's, vascular dementia, but also people that are have been caring for the rarer dementias and younger onset. We've also got quite an experience or difference in experience of the actual relationship. So we've got people like myself, adult children looking after parents. We've had husband and wife, carer and cared for. And we've also got experience from the other way of someone with young onset, or who was looking after someone with young onset who was their adult child. And that's really helped this group. But one of the things we really were quite interested in when we started working with students was these young people are really facing something quite difficult. We've all had experience of talking to primary care professionals, doctors, nurses, who have found it quite difficult to talk about dementia, particularly when they're talking about end of life and dementia. So these are experienced professionals who find those topics quite difficult. So we were quite worried about these young PhD students that were going to be going in and talking to people about those two difficult topics. So we suggested, how about they do a practice session? So this is pre-lockdown. We actually did it up in London. We had a day when we practiced the interview questions. And this sheet that you can see on the screen was some of the feedback. And we were very keen that we've captured feedback both from our group and from the students about how that day went, to inform them for doing their interviews, but also helped us to look at those interview sheets. It's all very well reading them, reading through when you're sitting in your armchair at home, but when you're actually practicing them with someone, there were some things that came up that, oh, actually, how would that work? And it was really, really enlightening, and it informed quite a lot of, for those sheets going forward. And I think we've got some comments, if we can go on to the next slide. And I'll let you read. So one's from me and one's from one of the students. So this is starting to talk about work that we went on, because following on from that opportunity where we all got together and the PhD students really got to know us and we got to know them, and we built up a real respect and trust. And because we then had COVID came along and we were going online, we had that opportunity, as Catherine said, to look at shorter meetings, but more often. So what we've actually had is people like Amel and the other students coming in and presenting their work to us. And it's really helped them, because what they're looking at is the kind of questions that they might want to ask us. So, well, first of all, actually, how to present to us. How do you present this information to a lay audience? But then what questions would be really useful for them to ask of us to inform their work? And also the feedback that we give them about the work they're doing, but also about the questions that they're asking. And I think we've just seen the confidence of the students and the things they're asking us it's just grown over the last couple of years. And it's been such a rewarding experience, I think, for all of us. But the other thing we've been doing, and the next slide will show, is we've had all the way through, we've kept a log of the you said we did. So this is the things that the patient team, participation team, have been actually suggesting all the way through. And as you can see, this is just one page of that log, and it's quite big now, of the kind of things that have come up during our meetings. And Charlotte, our administrator, has just been amazing at capturing all of this and then making sure that the team responds. And I've gone through it in preparation for this and just looking at the sorts of things we've been doing. And most of you will be, I think, used to this, but particularly with dementia, things like the language, the plain English, which we'll all be looking at, but also, and whether there's acronyms used, whether we need to produce a glossary, but also if someone's living with dementia, they might have particular feelings about some of the phrases that are used. Are they appropriate? There's words like suffering. People with dementia don't like us to use the word suffering when we're talking about dementia. Things like toileting, when we're talking about, someone being toileted, it's very inappropriate. so we can make sure that all the language is right. We're also looking at the layout of the material, so things like the type and the size of the text that's used, the color of the text in the background, and that can vary from person to person. Sentence length. If you have too long a sentence, will someone with memory problems actually be able to understand the sentence when they get to the end of it? Have they remembered the beginning and the point we're trying to make? The length of the paragraphs, the spacing between them, and the layout. Again, someone who's reading, who's got dementia, might find things just very difficult to read if it's all crammed into one page. So actually looking at the layout, and that's helped with our patient group, but also to create the materials for people who are taking part in the study. We've looked a lot about photographs and the drawings. Do they make sense and are they appropriate in those materials? We've looked at preparation for meetings, both the in-person meetings originally and in Zoom. How do we support people who are living with dementia with a diagnosis in actually taking part in those meetings? The environment, whether it be in person or on Zoom. Support getting to meetings or getting into a Zoom meeting. That can be really important to make sure that people are comfortable, that we prepare them beforehand and then actually for the meeting itself. And then we've looked an awful lot at the materials that are used for the project, and also things like the questionnaires. How do they come across if you're looking at them? Helping to clarify some of those issues, as I mentioned, particularly the practice session. Looking at sharing of ideas for materials, and also things that we've seen in other projects or materials we've used in support groups to bring into the project to help with the project team. And we've looked at ideas, how do we keep participants to the project engaged with the project? And it's really been, it's such a rich, as I've gone through, mining information in there, it's really rich for the project. And I think I've already talked to Catherine about what we can do in the future and maybe produce some papers or something that's an output from the project that adds into the project.
Okay, thank you, Jane. So just very quickly, the second component that we were able to change really, and the advantage of working virtually, was to widen the involvement of people affected by dementia. So we'd always planned within the programme to work with a group called DEEP, which means Dementia Engagement Empowerment Project. So this is a national charity supporting people affected by dementia, and it has groups that run across the country. So we were able to put out a call through the national group to say that we were looking to work with one of the DEEP groups on the programme. And previously we wouldn't have been able to do that. We probably would have gone to a group more locally in London. And this enabled us to work with a pathways group. So that's what they call each individual group in Bradford. And so that was wonderful for us as a research team based in London to be able to have opportunity to work with people affected by dementia in Bradford. And we met with them on 2 occasions. We're planning to meet with them again a couple more times across the programme. And by this point, we had got much better about conducting Zoom calls. And just as Jane was saying, in being supported by our public contributors as to how to do this well, to enable people living with dementia to be able to be involved in research and participate virtually in that contribution. And then the picture just shows one of the meetings, and there's just a little bit of detail on the 2 involvement meetings that we held with the group. And again, after the group, we asked for evaluation and feedback. So it meant that when we held the second group in November, we'd got better at what we were doing and how to use that space well to enable people to feel that they could be actively involved. And then finally, I'd just like to say thank you. So in particular, those are the names of our public contributors who've given permission for us to share their names with you, and also members of the research team. And this is a picture of us right at the beginning when we were brainstorming what the programme was going to look like, and that our public members, so Jane was involved with us as well as other individuals in helping us to design this programme that was then successfully funded by the Economic and Social Research Council. So that's everything from us. Thank you very much and welcome any questions.
People who aren't yet involved and don't work in the research field, especially those with high health and care needs, often made worse by inequalities. My own interest in health and care research largely arose from trying to make sense of issues facing me, my family and neighbours, and to give patients and communities a greater say. Beverly, what led you and Mosaic to get involved in research and to keep up that involvement amidst a pandemic?
I would say we was asked, really. We was approached by Josephine, and during the pandemic it was just a difficult time for some of our members because there was loads of conspiracy stories going around, people not trusting, and I feel like the members just needed someone to, you know, to share their experience with. And one of the things the governments were making very clear was that people of a BAME community stood a higher risk of dying from COVID. So that in itself made a lot of people from the BAME community believe that they were being killed, or, you know, they just didn't believe anything that they heard. So when the opportunity came for them to sort of share their stories, I thought, you know, this would be really great because it will mean that the lessons could be learned. We don't know if this is going to happen again, but, you know, the fact that they're able to share their story, maybe even just talking to somebody, you know, that might help. And we also had, like, we was quite fortunate. We only had a couple of members that did die from the pandemic, but there was one in particular that he came in to work and he had diabetes. And I said to him, you know, you're a high risk group. You shouldn't really be here. You know, you're the first group of people that has been told to stay in your home. And he was like, well, I don't actually believe that. You know, I believe that that's just something that's been said and I don't believe it's true. So then we had the weekend. By the Monday, believe it or not, this person had passed away. They found him in his house. He had COVID. So he wasn't alone and people hadn't heard from him for a while, and he died. And then we had many other examples of members that ended up in hospital because of their underlying conditions, and they weren't able to see people, and, you know, that they really struggled. So I thought this is a really good opportunity to share your story and also to see if there was anything that could be learned from it. You know, and the members really wanted to do that. So when Josephine asked us, we were like, yep, let's have a go.
Yes, I think that's a really sad example of some of the tragedies that can happen and have happened because of a mistrust, which one can also understand, of researchers and perhaps the wider authorities and sometimes the health service within Black, Asian and minority ethnic communities, sometimes among some disabled people, among maybe some people who are highly economically disadvantaged or in other ways feel alienated and pushed to the margins of society. What do you think researchers could do to build greater trust and also to help research to reflect what are the burning issues for those people, rather than it feeling as if researchers come in from the outside, so to speak, with their own agendas?
Yeah, and I think you're right. I mean, when even for me to think about the questions that I've had to answer today as a person that's not really been involved with research, I just thought, you know, how would I describe research to somebody who had no understanding of it? And it was so basic. I just thought, you know, it's an opportunity for someone to share their story, to promote change. That's as basic as I put it, and that's how I sort of sold it to my community. But I think one of the things that came up was mistrust. Some people say, what are you going to do with my information? You know, I've sat and I've spoken to this person. I don't know who they are. What are they going to do with it? And the fact that I was that link, I say, well, you know, I can explain to you what they're going to do with it. It's real worthwhile you doing it. Think about people that have lost their lives. Think about, you know, how we could could make a change. So that really encouraged people to do it. But also, I think when we have researchers coming into Mosaic, sometimes they come in and then you never hear anything else again. And then people think, well, what happened? And if you don't actually hear the next step, sometimes you can think, why am I doing this? Because it just feels like I've spoken to so many people and I haven't seen any outcomes. So maybe each person that you've spoken to, you could actually say to them, this is what we've done. This is the paper we've written in probably plain English that people could understand, and that your input has been really effective. You know, I think it's as simple as that. It's not just about coming in, getting this information and then disappearing with this information. It's about, you know, once you've finished that research, this is what we have. And you helped us to achieve this. So it's quite encouraging for that person to know that they've made a difference. So I think that's another thing. And also to have researchers that look like us, because you don't want to start off talking to someone and then having to explain what you mean. Like, oh, I went out for Sunday dinner and I had this, oh, what is that? And before you get to the point of why you're actually there, you're describing your home life and why you're eating certain things. So it'd be nice to have someone that's got something in common with the person that's actually asking the questions. And to go back to language, I work with over 400 members and it's in the middle of Brixton, so a lot of the members I work with are BAME. So I make sure that my language stays really clear and it doesn't become wordy. So I think that's a part of it as well. And the research that we got involved with Josephine, when the members all left, they felt heard and they felt that they could relate to her. So it was a really positive experience for them.
Thanks. I think that's some really important points there about building trust, about research in the heart of the community, about being clear about what you're saying, reflecting communities you're researching. And I think that idea about sharing stories to promote change is so important.